The topic I have chosen for my PowerPoint is multidisciplinary patient care in the patient environment, and I'll be focusing on the benefits surgical checklists have on promoting teamwork in the operating room, ultimately improving patient safety. So what is multidisciplinary care? Multidisciplinary care involves the collaboration of different areas of the healthcare team, different fields of health working together, communicating with one another, assisting and helping each other, all to help improve a patient's condition. When we look at the operating theatre, this team commonly involves the surgeon, the anaesthetist, the anaesthetic nurse, the circulating nurse, and the instrument nurse. While each of these positions have different responsibilities and roles in an operating theatre, they need to work together as a team, with constant communication and assistance being made between them. Good teamwork improves patient outcomes by reducing the amount of preventable complications in surgery. The World Health Organization realizes that there was a high amount of surgical complications happening within the operating theatre. In industrialized countries, the rate of major complications in surgical procedures ranged from 3 to 22%, and a mortality rate of 0.4 to 0.8%. It was determined that half of these events were preventable. That may not seem like a very large number, but if you think about the amount of surgeries that happen each day around the world, then you're talking about a significant number of deaths that can be prevented. So the World Health Organization came up with the guidelines for safe surgery in 2009. This aimed at providing healthcare facilities around the world a basic set of universal guidelines that can be used in the operating theatre to reduce surgical complications. One of the tools included in this guideline was the surgical checklist, a list of checks to be conducted before the patient is anaesthetized, then more checks before the operation begins, then lastly checks before the patient leaves the operating theatre. This is a picture of the checklist. Hales and Provost 2006 state that a lot of studies into checklists have come from the aviation industry, which is not unlike the operating theatre in that it is also a very high risk environment. Checklists are simple tools that have the capacity to reduce errors in the operating room. Checklists are usually a list of tasks or actions that are arranged in a certain order. The objectives and benefits of checklists include helping remember certain tasks by jogging your memory, standardizing processes, regulating processes by ensuring minimum standards are being undertaken, and promoting communication. A study by Hayes et al. 2009 was undertaken to see if the introduction of a survival safety checklist is able to reduce the amount of complications in surgery and reduce mortality rates. 8 hospitals across the globe took part in the study, with the hospitals chosen being from both developed and developing countries. Data was collected by a total of 3,955 patients over nearly a year. The results were very positive. Before checklists were introduced, the rate of death was 1.5%. After the checklist, this moved to 0.8%. The rate of any complications moved from 11% before introduction to 7% after. All sites reported reductions in their mortality and morbidity rates. This study provides great evidence towards the benefits of the introduction of checklists. A study by Vries et al. 2010 backed up the results found in the previous study. Vries and his team conducted a similar study but used only hospitals with a high standard of care. Vries et al. Saw complication rates from 27.3% reduced to a rate of 16.7% and a mortality rate reduced from 1.5% to 0.8%. Vries et al. Also had control hospitals in their study. With no implementation of the checklist, rates remained the same. Vries and his team came to the conclusion that the checklist improved outcomes by not only preventing adverse events by reminding staff to perform tasks, but also it was a useful tool in promoting communication between the multidisciplinary team, which in turn improved patient outcomes. So what is the current situation in our hospitals? New South Wales Health has a policy directive that has been developed to implement the principles of the World Health Organization Surgical Safety Checklist. The policy directive states that it is aimed at improving the communication between the team members and reduce clinical procedure incidents. It states that every member of the team that is involved in a procedure is responsible for making sure that the process is followed. For surgical procedures using sedation in the operating theatre, 3 stages of the checklist need to be conducted. The team timeout is an important part of the checklist. The policy directly states that all members of the procedural team need to be involved in the timeout, and everyone must agree with the aspects of the timeout section of the checklist before anyone can continue. This is the time where any member of the team may voice the concerns they have with the operation. Timeout is heavily dependent on the effective communication between the team. The checklist is a team effort, with each member of the team contributing their part to the completion depending on what their role in the theatre is. ACORN standards describe the nursing roles in the operating theatre. The anaesthetic, circulating and instrument nurses all must act as part of the team. All three must partake in the timeout. ACORN also has a good example of how multidisciplinary teams can work with the checklist. An example is found when looking at the roles of the circulating and instrument nurse. While the standards state that it is the primary responsibility of the circulating and instrument nurse to make the count of accountable items, they also state that it is important that all members of the team are involved in the counting process. It needs to be a collaborative effort. The surgeon can check the incision site while the instrument nurse counts the items on the tray. Although a systematic review has shown that compliance levels for the surgical checklist are high, they are still not 100%. So what are some of the complications that arrive by implementing a checklist? Manajan 2011 describes possible barriers. Anxiety due to team members being unfamiliar with the checklist. Some people may find the checklist hard to get used to and may also be intimidated by having to introduce themselves. Certain cultures may find this particularly difficult, but alternatively, they may find the checklist helps them get over the communication barrier. Hierarchy in the operating theatre also may create problems. If the nurse is trying to get the checklist completed, the anaesthetist or surgeon may not comply. Compliance is a lot more likely if the surgeon or anaesthetist is supportive of the checklist. Healthcare facilities have a role to play in trying to get rid of hierarchy in their operating theatres. Education on the benefits of checklists may also help with this issue. Another barrier may be the timing of the checklist. The earlier parts of the checklist may not be able to complete it because the surgeon may be off seeing other patients, and also timeouts may be difficult as they are usually conducted while everyone is in their busiest. A solution to this issue, I believe, would be that the more familiar the team becomes with using the checklist, the better they will get with the timing. Also, working with a familiar team may also improve efficiency. Lastly, checklist fatigue may be an issue. With so many checklists and documents needed to be completed by nurses and other healthcare staff, there is the possibility that they will be overwhelmed by the checklist and discredit their importance. One solution in the future, I believe, would help is the implementation of electronic checklists. With this, I feel there would be less room for error, also improve the speed of the count by the nurses, and possibly even improve compliance. Thank you for listening. Here are my references. Thank you.